Okay, we'll start after our noon recess. I believe Lincoln County Health is done with their initial presentation, and we'll turn it over to the foundation.
Thank you. As some of you know, I actually am a part of this community. I've lived in Booth Bay for almost 30 years. Part of what makes this place so special is also a problem. We're isolated. We can't make comparisons to other communities like Portland or even Damariscotta because we're more akin to an island being on this peninsula. I can envision times when there would be no access off the peninsula if there were an accident or some other issue at one of the critical roadways. We're looking to keep our ER open, or we were looking to keep our ER open, and that was denied. And we have a voice here today to try to make sure we don't lose anything else. Lincoln Health or Lincoln County Healthcare, whatever they're calling themselves, is looking at money. They're not necessarily looking at lives. They tell us if we want beds, we can't have the 24-hour urgent care. That's not the issue here. It's not all about money, and there's no guarantee that even if they put those beds in, that they would stay. It's a slippery slope we're on, and if we don't stop it somewhere, we're going to be left with nothing. So just to be clear here, our goal today is to abide by the Commissioner's condition number 3 and keep 24-hour urgent care services in place. And we have witnesses today to testify that there are several different models that accomplish that objective. The Commissioner's third condition was based on concerns voiced by the community, and it should be upheld. And I think it would be relevant at this point to just actually quote from the letter that she submitted agreeing to the merger and specifying the conditions dated May 27, 2014. Commissioner Mayhew says, I have determined that the ordinary economic development of healthcare for the Booth Bay region would be adversely affected, and this specific application would have to be denied if the applicant who provided acute emergency care was not required to maintain an appropriate urgent care presence. The commenters have made this need clear, and I have approved, including a condition requiring 24/7 urgent care services. That's all we're asking for today. Thank you.
Thank you. First witness.
David, or does he kill himself?
Just go right through the questioning. Do you have your...
Raise your right hand.
Yes.
Repeat it. Or do you swear or affirm the testimony you're about to give is the truth to the best of your ability and belief?
I do.
Thank you. Have a seat.
Please state your name, title, and your address here on the Booth Bay Peninsula.
My name is David F. Rassicott, MD. I'm retired. I live at 2 Sunset Road, Booth Bay Harbor, 04538. I'm a 6-month resident of Booth Bay Harbor, residing in Virginia during the winter months. My wife and I had planned to move to Booth Bay Harbor year-round, but have put those plans on hold since the hospital closure.
Please summarize your expertise as it relates to the matter before us.
I am a retired family physician. Much of my career was spent in the United States Navy, 32 years of commissioned service, and 27 years of active duty. I also had several years of private practice experience in rural north central Massachusetts, as well as several months locum tenens experience in 2 locations in rural Maine. My Navy experience includes that of being medical director for 2 hospitals, where I was responsible for all medical services, including the emergency department. I have been responsible for 24-hour emergency services at 3 locations and have personally stood in-house watch for years as the sole physician in the emergency room and often the only physician in hospital. In my last Navy position, I was medical officer for Surface Forces Atlantic Fleet. I was responsible for manning, equipping, training, and maintaining the medical departments on board all surface ships of the Atlantic Fleet, including amphibious ships, which were readied as hospital ships during the Second Gulf War. Therefore, I know something about pre-hospital and emergency care, especially in rural and isolated environments. My credentials pertaining to the delivery of primary care include nearly 30 years of medical practice as a family physician, experience teaching in 2 family medicine residency training programs, and 4 years as advisor to the U.S. Navy Surgeon General on all matters relating to Navy family medicine.
What is the purpose of your testimony here today?
My purpose is to advocate for 24-hour medical care for the Boothbay Peninsula and to briefly describe 3 ways in which that could be accomplished. By the following. 1. Upgrading the current urgent care center to a freestanding 24/7 emergency room. 2. Number 2, using an alternate staffing model for the 24-hour urgent care center, which would result in a clinically appropriate and affordable solution. And lastly, integrating the 24-hour urgent care with the current family care center.
Why do you feel that 24-hour access to care is appropriate for the Boothbay region?
Healthcare is a 24-hour profession. I believe that Lincoln Health has an obligation to provide timely and proximate access to 24-hour health care for the Boothbay Peninsula. People get sick around the clock. We are geographically isolated on the Boothbay Peninsula. If you were to choose any time when an urgent care center should be open, it would be when the primary care offices are closed. Lincoln Health is denying patients timely and appropriate access to local care after hours. Patients on the Boothbay Peninsula with an ambiguous medical complaint in the middle of the night have nowhere to turn for timely advice, nor do their clinicians have any recourse for local disposition of their patients, except to send them off the peninsula. The Commissioner agrees. Her opinion is clearly stated in her letter of 27 May 2014, in which she approved the Certificate of Need with the stipulation that Lincoln Health provide 24-hour urgent care at the St. Andrews campus. The Commissioner's requirement was based on the closure of inpatient beds and the emergency department of St. Andrews Hospital, leaving the residents of the peninsula with the sole option of traveling off the peninsula for emergency care at all hours and for urgent care after the closure of the presently established urgent care center at 8 p.m. The Commissioner's decision is both morally correct and medically appropriate.
What is your opinion of the currently operated urgent care center at St. Andrews?
The currently operated urgent care center at St. Andrews campus of Lincoln Health is a confusing paradox. It operates as a mid-level urgent care center, advertised as a treatment center for only minor illness and injury, but is staffed with the same physicians and nurses and with the same lab and x-ray coverage as when operating as an emergency department. This is confusing for the public and excessively costly for the stated mission of the urgent care center.
How do you think that confusing paradox should be addressed?
Lincoln Health must decide what the St. Andrews facility is to be. If staffed by emergency physicians, it should be a freestanding emergency room, providing a real service to the community and relieving stress and cost for the peninsula's ambulance service. A freestanding emergency room would accept ambulance runs and facilitate appropriate direction of ambulance transfers to the correct next level of care, whether that be in Damariscotta or a larger hospital. As stated in my previous letter to the Commissioner, dated 18 December 2013, which I've included as Exhibit 1, I believe a 24-hour freestanding emergency room for the treatment of urgent care level problems and the initial assessment, treatment, or stabilization of more serious conditions is the most appropriate medical decision for the community for 2 reasons. First, it solves the 24-hour access problem for patients and clinicians. And second, it allows immediate assessment and more appropriate and more timely disposition for patients requiring a higher level of care not available in Damariscotta. Patients requiring higher levels of care now suffer the risks entailed in an initial ambulance ride, which may be triple that of the duration prior to the St. Andrews Emergency Department closure, only to get to Miles Hospital to find that another ambulance transfer is necessary because of the lack of beds or services required. Costs to the overall healthcare system and risks to patients could be more properly minimized by initial evaluation on the peninsula and transfer to the appropriate facility after initial evaluation and stabilization at St. Andrews. While I recognize that healthcare has become a business and that profit becomes a controlling issue, community service and the provision of appropriate local healthcare access for all communities, especially one isolated by winter storms or busy Route 1 summer traffic, should be the central focus.
The Department of Health and Human Services Commissioner's condition requires the facility to provide 24-hour urgent care service, not to provide a standalone ER. How should that urgent care service be staffed, in your professional opinion?
If the facility is to be an urgent care facility, there are more creative staffing solutions that could make a 24-hour urgent care center financially sustainable. Other rural urgent care centers in Maine operate with mid-level clinicians, nurse practitioners, and physician assistants. Utilization of these clinicians at the St. Andrews Urgent Care Center versus emergency medicine physicians could represent a cost avoidance of nearly $500,000 per year. The skill level of mid-level clinicians is ideally suited to the currently stated scope of care for the urgent care center, as described by Lincoln Health Emergency Medical Director Tim Fox in his 16 December 2013 interview with Booth Bay Register, which I've submitted as Exhibit 2, and in patient information brochures produced by Lincoln Health. Use of emergency room physicians for urgent care is unnecessary and simply not sustainable from a cost perspective.
You say that mid-level clinicians would be more appropriate. Could you be more specific?
Yes, I have provided a spreadsheet, Exhibit 3, that represents an alternative staffing proposal for the urgent care center from 8 p.m. until 8 a.m. In fact, I feel that staffing levels proposed may be appropriate during daytime hours as well, and would yield the full cost avoidance that I've described above. In busy summer months, additional staffing may be needed during peak service times. Further cost avoidance could be realized utilizing CLIA wave testing at night versus routine laboratory testing, which would require a laboratory technician. It is anticipated that the radiology technician would be underutilized and therefore available to serve in additional clinic roles. If the volume after 8 p.m. seems light, follow-up of patients seen in urgent care who do not have a primary care clinician on the peninsula could be provided, instructing them to return for wound care, suture removal, etc. on subsequent evenings. If Lincoln Health is uncomfortable with mid-levels at night, mid-levels could be used during the daytime when there are multiple practitioners available as consultants, and emergency physicians could stand watch at night when independent decisions are required.
What is the third alternative you propose?
The dilemma for providing 24-hour accessibility for the Booth Bay Peninsula presents an opportunity. There exists the potential for fully integrated, self-sustaining, 24-hour primary care if pursued with energy and imagination. The optimum way to provide follow-up for patients seen in urgent care would be for the urgent care mid-level clinicians to have some office hours in the family care center, and perhaps some of the clinicians presently working at the family care center could be enlisted to provide some care in the urgent care center. Especially during the high summer season, there are inadequate numbers of primary care clinicians on the peninsula. Providing additional primary care clinicians at the urgent care center and integrating them with the existing clinicians at the family care center could provide a cost-effective, self-sustaining, appropriate primary care practice, providing continuity and 24-hour care for all. It would meet the patient's need and build Lincoln Health's primary care base.
Would you please summarize your recommendations?
I believe a 24-hour freestanding ER to be the most appropriate medical decision for the community. If Maine Health and their partner Lincoln Health truly cannot afford to run an emergency room on the peninsula, we are left with two other reasonable alternatives that answer the requirement of the Commissioner for 24-hour urgent care. First, 24-hour urgent care center staffed by mid-level clinicians. Second, and most appropriately, a comprehensive health service that integrates urgent care and primary care and supports the patient-centered medical home, incorporating 24-hour urgent care center with the existing family care center. Lincoln Health should be compelled to abide by the original, carefully considered requirement of the Commissioner to provide 24-hour urgent care. Additionally, Lincoln Health should be compelled to work in cooperation with the community and with the Booth Bay Region Health and Wellness Foundation in particular to achieve the goal of integrated, sustainable, 24-hour primary and urgent care for the citizens of the Booth Bay Peninsula.
Does this complete your pre-filed testimony as of August 7th, 2014?
Yes, with the understanding that I may have the opportunity to respond to points that may be raised at the hearing by others.
Thank you.
Thank you. Cross-examination?
Doctor, in your Navy career, did you have any hospital management experience in which you had the responsibility for determining the sources and applications of revenues to properly support the clinical services being provided?
Absolutely.
And what was that?
I was the executive officer for the Navy medical clinics in the United Kingdom, and I was the medical officer for the surface forces of the Atlantic Fleet, where I was responsible for the care of 50,000 sailors on the ships of the Atlantic Fleet. And we had a fixed budget, had to decide where the money could be most appropriately spent for the best of all.
Where did you get your money?
We were awarded a budget from the federal government, and it was a fixed budget, never quite enough, is it?
But the fact is, you were dealing with military personnel in a military situation in which the amount of money made available to you was the amount of money the Defense Department determined that its military personnel would need to be properly cared for. Is that correct?
That is correct. That is correct.
You understand that's a different process than is used in private hospitals?
I understand that.
Thank you.
Absolutely.
Redirect?
Excuse
Oh,
me.
sorry.
Let me have another minute.
Standing by for more.
I thought thank you was the end.
I was thanking
Thank you for
him,
your help.
not you.
I appreciate your support.
You say in this testimony that you believe that Lincoln Health has an obligation to provide timely and proximate access to 24-hour health care.
Yes.
Are you here to testify as a person trained in the law that there is an enforceable legal obligation on Lincoln Health to do that?
I am not trained in the law. This is my opinion, and it's based on my medical experience and expertise. I believe it's a moral obligation.
So is it fair to say you think Lincoln Health ought to do what you want it to do, but not that it has an actual obligation?
I think that would be a wonderful idea.
Hold on. There's an objection. What's your objection?
My objection is based on the fact that we're working on the premise that it's already been established. Condition number 3 is in place unless this reconsideration hearing changes that. So I think legally there is an obligation as well until that decision has been overruled.
Well, that's what we're here for, the reconsideration of that condition. So I'll allow the question.
Did we copy
If
the answer?
you
Did you get the
remember.
answer?
Thank you. I'm moving on. If a patient with an ambiguous medical complaint in the middle of the night makes a sensible tactical decision, it would be on the conservative side, would it not? And go to the emergency
Oh,
department?
not by
Objection
any
calls for
means.
speculation.
And the
Well, it
answer-
does. I guess it depends on, let me answer for you. It depends on the individual case, but go ahead and try to answer that question.
It does, absolutely depend on the individual case, depends on their understanding of the condition based on their educational level, it depends on their transportation, it depends on their finances, it depends on many things. And patients err in both directions, as do doctors. Sometimes they're too conservative, sometimes they are, they seek care when they perhaps could have waited.
Well, let me try the question this way. A person with an ambiguous set of symptoms who really needs an emergency department or more care,
Yes,
who goes to an urgent care, has essentially made a mistake, correct?
I would disagree.
And why?
Because they've made the best decision they can, and because the person at the urgent care center can help them decide, or can help decide what the proper disposition for that patient might be. During the daytime, there'd be multiple clinicians who could be consulted, and at nighttime, if it's a very serious problem, that patient could be directed either to Miles, if that's the most appropriate disposition, or could be directed to Brunswick or Portland, whichever site suited the patient's condition most appropriately, and without having to go past go, without having to have another assessment at Miles. I'm sorry, that's correct, at Miles. Do you need clarification?
No. Any disposition that's not treated and released is going to require going somewhere else, doesn't it?
That's correct.
In terms of the financial constraints we're dealing with here, there's been mention made in your testimony about avoiding ambulance costs.
Right.
However expensive ambulance costs are, they don't even begin to compare with the costs of maintaining an emergency department, do they?
They are both considerable sums of money, and they come from different pockets, don't they? Who funds the emergency room? Lincoln Health. Who funds the ambulance service? The community.
And so my question was, don't we all just understand that the cost of an ambulance ride, however pricey it gets, is going to be very small compared to the price of the medical care at the other end of the ambulance
Objection.
ride?
Lack of foundation.
Right, and
I let a lot go in the other way. Let's hear your answer.
my answer would be, it depends.
And so, as far as you're concerned, the price of an ambulance ride could be so high as to be a material consideration in these financial analyses. Is that your testimony?
I'm not sure I understand what you're trying to ask me. What are you asking?
Can we have that question reread, please?
The cost of the ambulance ride could be so high as to be a material consideration in these financial analyses. Is that your testimony?
Well, I would say that patients who, given the fact we do not have an opportunity to make a medical assessment on the peninsula in the middle of the night, our patients often are subjected to more than a single ambulance ride. So, I mean, so yes, ambulance transportation is costly. It is something that patients are at risk when they're transferred by ambulance, at risk for pain, suffering, death, and if you subject them to 2 ambulance rides, it simply compounds the problem.
In your testimony, you say that healthcare is a business and profit becomes the controlling issue and so forth. Then you say community service and the provision of appropriate local healthcare access for all communities, especially when isolated by winter storms and busy summer Route 1 traffic, should be the central focus.
Yes.
Of whom?
Of anyone who cares.
And so the source of revenue to cover these additional costs that you advocate imposing would be what? Who?
That's always the ultimate question, isn't it?
Well, that's why I asked it, Doctor. Who pays for this?
These administrators are intelligent people, and I'm certain they can figure it out.
Okay. You submitted exhibits here with your model of how to run the place.
Yes,
You understand that under the CON, it can't be run to your model because the CON requires it to be run differently, and it would at least require a new CON process for the commissioner to allow it to be run your way. Do you understand that?
I don't think I do understand that.
Okay, fine.
Because I believe that a 24-hour emergency room is one very effective way of providing urgent care to the community.
I'm asking you whether you have any knowledge at all as to whether the institution is obligated to do what the commissioner directed it to do. And in its submissions, Lincoln Health submitted the staffing plan which you are disapproving. And to deviate from it would require another visit to the commissioner on another CON process. Do you not understand that?
What I understand is that I've provided an alternate way to do business, which could result in some cost avoidance. There are many other ways, I'm sure. And again, these folks are smart enough to be able to figure that out. There's more than one way to do business.
And so, in your exhibits, am I correct that your exhibits provide differential costs under your alternative model
Differences between,
between having the physician staffed
Yep.
and... So you've gone and compared costs,
I
correct?
have,
Is there anything on any of your exhibits that deals with reimbursements?
no.
So you have no idea what the reimbursements would be?
I'm certain that the reimbursements would be different.
And if the reimbursements are different and the costs are different, then your bottom line is going to have to differ to accommodate the difference in reimbursement, isn't it?
It would diminish, it would no doubt somewhat diminish the cost differential. However, it would also reduce the cost to the patient and to the insurance companies, to the state and to the federal government. And I think that's what we're after. I don't think
And-
we're after trying to
and you-
charge the maximum amount
You
to the
have data,
feds and the
you have,
state.
I'm sorry, I didn't mean to speak over you, Doctor. Would you say that again?
Yes, I would say that, you know, if we, if there's a differential between what we would charge for mid-levels and for emergency physicians, if mid-levels are appropriate in terms of their scope of care, might be more appropriate because to provide care at a lower cost, because that, we would have lower costs, those lower costs would be, it would cost less for patients who are not insured, and we would be charging the state and the federal government less money for the same service.
And we all agree that the costs and the pricing are important considerations for everybody on all sides of every one of these conversations,
Yes,
correct?
yes.
Now, as part of your alternate model, if I'm understanding your testimony, you say volume after 8 p.m. seems light. Follow-up of patients seen in urgent care who do not have a primary care clinician on the peninsula could be provided. Do you know how many people that would be?
I don't.
And instructing them to return for wound care, suture removal on subsequent evenings, so you'd be requiring people to come between 8 p.m. and 8 a.m. because that's when the load is light and we have personnel waiting around.
We wouldn't require them, but if it were convenient for them, that would be a preferable time.
You don't have any idea whether that's one person or 20 persons or what that
No,
would do?
neither of us do.
Exactly, but you're the witness. So you don't have any idea what these numbers would be, isn't that right?
That is correct.
Excuse me, may I have a moment?
Yes.
Nothing further, thank you.
Redirect?
Doctor, do you feel that the fact that Lincoln Health is already planning to staff the urgent care with ER doctors gives you a basis for your recommendation that it would be the next level just to make it into an emergency room again? Is that enter into your opinion?
Yes.
Do you feel that the first responder is important, whether or not it's a doctor at the St. Andrews campus versus an EMT?
Clearly.
Do you feel that 2 ambulance rides, maybe one that's unnecessarily going from St. Andrews 2 miles, would be detrimental to a patient who really should be directed at the first instance to Brunswick or even Portland?
Absolutely.
Do you think that could have a different effect on outcome, life or death?
Absolutely. And if not life and death, certainly pain and suffering, or increased morbidity.
And based on your experience in the Boothbay community, do you think it's possible that donations would be a large source of funding if the ER was reopened?
Speculation.
Sustain.
I couldn't.
That means
say.
you can't answer that question.
Yes, sir.
That's all I have.
Thank you.
Mhm.
Thank you.
You're welcome.
Recross?
Yeah, just one question.
Yeah.
You understand that in modern medicine, an emergency department has more than a single emergency doctor in order to provide appropriate team response in an emergency, don't you?
No,
Nothing further.
no.
One question or none?
One question. Do you think it's possible for a lone emergency room doctor to provide a meaningful service?
Absolutely.
Thank
And
you.
I have done it time and time and time again. Yes.
Thank you.
Good, good. Thank you.
Next witness, please.
Raise your right hand. Do you swear or affirm the testimony you're about to give is the truth to the best of your ability and belief?
I so swear.
Thank you.
Please state your name and address.
My name is Gerald Homer. I live at 96 Annabelle Road in Boothbay, Maine, 04537. I have been a resident of Boothbay since November 2005, and I've owned property here for 20 years. I'm a retired hospital administrator, having worked in various hospital administrative positions for 22 years. I was recognized by my peers as a fellow in the American College of Healthcare Executives.
What is the purpose of your testimony today?
My purpose is to advocate for 24-hour access to medical care in the Boothbay Peninsula.
Why do you think that 24-hour access can be provided in an affordable and financially sustainable way?
Lincoln Health argues that it is too costly to provide 24-hour access to urgent medical care on the Boothbay Peninsula. In my experience, community hospitals have not evaluated financial feasibility based solely on the profitability of one particular service. Some hospital services are understandably and necessarily loss leaders. Some losers will be maintained because of their critical need, or because they otherwise contribute to the overall profitability of the institution and feed inpatient or other outpatient volume. The critical need for access to care in this case weighs more heavily than profitability, and access can be maintained at lower cost than proposed by Lincoln Health.
How do you evaluate quality of care?
The first criterion is access. The best quality of care may be available, but if it cannot be accessed easily, conveniently, and timely, it may as well not exist. Many medical problems may present ambiguous symptoms, and the severity of the condition may not be easily determined by a worried patient. Having easy access to prompt diagnosis and treatment will identify those serious emergency conditions and resolve those less serious problems. Difficult and expensive transportation to a distant emergency room in the middle of the night could lead patients to delay appropriate treatment. A recent study referenced in the August 4th edition of the Los Angeles Times, which is submitted as Exhibit 4, finds that when a hospital emergency room closes, people in the surrounding neighborhood suffer. The study reports that patients affected by ER closures were 5% more likely to die after being admitted to a hospital than were patients who didn't lose an ER in their neighborhood. Closure of ERs leads to longer wait times for treatment. It also means patients have to travel further to get emergency room care, and it may prompt some to simply stay home. All of these factors force patients to wait longer and perhaps get sicker by the time they are admitted to a hospital. The study reports that these ill effects particularly impact low-income and older patients. Both of those demographic categories are prominent in our hospital service area.
How do you resolve the conflict between quality and cost?
Providing the necessary service at the lowest possible cost can affect the quality-cost balance. Lincoln Health is proposing to offer urgent care with emergency room staffing and higher cost, thereby tipping the balance toward cost consideration. Providing more appropriate mid-level staffing, as do most urgent care centers, lowers cost and tips the balance more toward providing a needed service. It is also difficult to put a dollar value on access and quality if reduced access costs lives. How many lives need to be saved by providing more prompt evaluation, diagnosis, and stabilizing treatment to justify the expense? 10 lives per year? 5? 2? Perhaps only 1?
Does this complete your pre-filed testimony as of August 7, 2014?
Yes, with the understanding that I may have the opportunity to respond to points that may be raised at the hearing by others.
Thank you.
Thank you. Ross?
Sir, what years were you in a hospital administrator position?
Beginning in 1973 until about 1992.
And you did not work in such a position after 1992, is that correct?
That's correct.
And after you left the position that you had in 1992, did that essentially terminate your status as a fellow in the American College of Healthcare Executives?
Yes,
And so for 20 years, you have not been a hospital administrator or a fellow in that organization, is that right?
correct.
Excuse me, ma'am?
Yes.
Nothing further, thank you.
Thank you. Redirect.
Do you feel that healthcare has changed so drastically in the time since you've actively been involved in it that the comments that you might make are no longer relevant?
Object to his foundation for knowing that.
No, that's true. Sustained.
I don't have anything else.
Thank you. Raise your right hand. Do you swear or affirm the testimony you're about to give is the truth to the best of your ability and belief?
It will be.
Thank you. Seat.
Please state your name and title.
Nancy J. Oliphant, MD. I'm family physician in private practice. I've practiced in Booth Bay Harbor since 1997. I reside at 13 Ridge Road in Booth Bay. My practice is located at 185 Townsend Avenue in Booth Bay Harbor.
Before we go on, I've heard it twice. If you have a cell phone or other device, could you shut it off or put it on quiet? Thank you.
Have you seen any demand for care between 8 p.m. and 8 a.m.?
Yes, I have. I am unable to cite names or identifying details of the patients because of HIPAA regulations, but I can say that during the first week the emergency department was closed, one of my patients called me after 8 p.m. with a lacerated thumb. He came to the office and I sutured it, and that's certainly something that could have been handled by the urgent care. Within 2 weeks of that time, a patient called after 8 p.m. with palpitations and extreme anxiety. She refused to call an ambulance, but agreed to let me call the ambulance if an EKG in my office showed there was a serious problem. Fortunately, it did not. At least once a week, a patient will come in saying, if the emergency was open, I would have gone there last night. The reasons I hear for not calling 911 include ambulance expense, not wanting to be taken to Miles. People are quite vehement about not wanting to go to Miles. Not being sick enough to justify an ambulance, but unwilling/unable to drive themselves to an ED, worrying that they will be stranded in Damariscotta or Brunswick and unable to get home. Several patients have presented to my office with injuries that, while life-threatening, were frightening or painful for the patient. One gentleman recently dropped an X-Acto knife on his foot at 4 a.m. It stuck in the dorsum of his foot, bled enough to frighten the patient and his wife. It could have used sutures. He came in for his regular appointment 4 days later, by which time it was too late for suturing. To a frightened patient who is bleeding or is in pain, the definition of emergency is quite a bit broader than just life-threatening.
Do you consider being unable to get medication to be an emergency?
Under some circumstances, yes. After Rite Aid closes, there is nowhere on this peninsula to obtain prescription medication for even a simple bladder infection. Now, a bladder infection is not life-threatening, but anyone who has ever had a bladder infection will testify to the discomfort involved. And a delay in treatment can lead to pyelonephritis, which can be life-threatening.
Does this complete your pre-filed testimony as of August 7th, 2014?
Yes, with the understanding that I may have the opportunity to respond to points that may be raised at the hearing by others.
Thank you.
Russ?
Doctor, I'd like to take you back, if I may, to line 16 on the first page of your testimony.
Certainly.
I may have misheard you, or you may have misread it, but that line does say, while not life-threatening. Is that not correct?
That's exactly.
Thank
Or
you.
frightening or painful.
All right.
Mhm.
And the gentleman with the cut foot came in 4 days later, not the next day, right?
No,
Right?
right.
Right. Thank you. Do you think this community needs more skilled nursing beds?
Absolutely.
See, I have nothing further.
Redirect?
Do you feel like it's appropriate to have beds versus nighttime urgent care? Is that an appropriate question for the community?
The community used to have both. It should not be required now to make a choice.
And to your best of your knowledge, why does the community no longer have those beds?
Because St. Andrews was closed, removing 25 beds from this community, and Miles was downsized, reducing their beds from 38 to 25.
So they took the beds away and now they're offering the beds as an option, an alternative to nighttime urgent care. Is that your
Check to the
understanding?
form
Yes.
and foundation of the question.
I'll overrule that. Your answer is yes?
The answer is yes.
Do you have any confidence based on recent history that if those beds were offered, they would actually be established?
Irrelevant.
Well, irrelevant and
They raised the issue.
speculation, who knows?
I'm saying irrelevant in the sense that the confidence or not of one physician in the community is not probative.
It calls for speculation. We've gone there, any event, sustained.
That's all.
Thank you.
Thank you. Recross?
Nothing further, thank you.
Thank you. Any more witnesses?
We don't.
Okay. I'm going to let the public speak before I let, or rebuttal. Well, let's do the
Okay.
rebuttal. No, I'm running this, not you.
I understand you told me we would do that.
I've just changed what I was about to say. So, I'm going to allow the attorneys to do their rebuttal, which means Lincoln County is going to put on some witnesses or a witness to address some of the direct testimony the foundation has presented. And there'll be limited cross-examination of those witnesses, and then we'll do the same for the foundation. And then you'll have your chance to come up and speak for, against, or neither. Thank you. Lincoln County.
Thank you. Mr. Prenti?
Would you raise your right hand? I don't think you've testified yet.
No,
Do you swear or affirm the testimony you are about to give is the truth to the best of your ability and belief?
I do.
Thank you. Have a seat.
State your name, please, sir.
Wayne Prenti.
Where are you employed?
I'm employed by Lincoln County Healthcare.
What is your position there?
I'm the Chief Financial Officer.
In the course of your duties as Chief Financial Officer, have you been involved in the planning and financial arrangements for the changes that have occurred here in this community?
Yes.
With respect to the question of the staffing of the the urgent care center after the closing of the emergency department, was consideration given to using mid-care professionals?
Yes, since the beginning of our evaluation process, we looked at both staffing the 8 p.m. to 8 a.m. hours with physicians as we do now during the day and with mid-levels in those late hours. Both calculations have been made since the beginning of our analysis.
And after and as a result of the testimony presented by the foundation concerning alternate staffing models, did you then prepare exhibits at my request?
Yes, I did.
And those exhibits have been up here on this board, is that correct?
Yes.
I would offer for the record exhibits 2A through 2D. I've provided copies to council. These are the same as what's up here.
Any objections for the record? No? Okay, thank you.
Best case. This one. So 2A is the urgent care operating loss best case model, correct?
Yes.
Would you, as briefly and as clearly as you can, explain what you have done here so that people can understand?
This format is similar to the exhibits already submitted, with the essential change being that in the additional hours section, we have incorporated our assumption of that being staffed by mid-levels instead of physicians. And you can see we'll get to the comparison in a moment, but even with the reduction in direct expense, we have a substantial offset in net revenue because of the cost reimbursement components of being a critical access hospital. There is a trade-off. It is less. Overall, the question becomes, is that amount worth the trade-off? However, even in so doing, we still have a $659,000 loss for operating the hours of 8 a.m. or 8 p.m. to 8 a.m. And this particular scenario,
You're pointing at 2B, I think?
Any on 2A? No?
Best case.
this is best case.
I'm sorry, you're right, it's 2B.
Okay, if you could identify the exhibit you're referring to for the record,
Okay.
that'd be helpful to the
Mine
commissioner.
is not marked D, B, and,
Well, they're in the order you have. A is on top,
okay.
but I put the wrong slide up. So this is 2B, and so we might as well finish it.
2B's on the bottom.
Everything we have done with two baseline assumptions regarding volume. The case before you, we've called the best case model because it assumes a 36% increase in patient visits from 8 p.m. to 8 a.m. than we saw in the last year of operation of the emergency room. 36% more than actually came through the door during fiscal year 13. And still, we have that loss of $659,000. My fingers aren't real good at this balancing act.
So this is the best case, the 36% case. The alternative you've called the likely case, and what is the assumption there?
The assumption in the likely case is just going by the numbers that actually exist. And 592 is the number of patients that did come through in fiscal year 13, between those hours that did not arrive by ambulance. As far as the appropriateness of that year goes, that 36% that we also present in the other assumption more than covers many years of increase. And so if you're looking at the range, I think we've covered conservative to any case of problem.
That bottom one, is that, excuse me, 2A?
Well,
These were numbered after I saw them.
yeah, and I'm hoping that we all have them in the same order. I should have been doing more paralegal work instead of eating. But,
What's the letter for best case model?
well, the only person who knows is the chair. What does 2A say on the top of yours, please?
2A says urgent care operating loss, best case model assuming 36% growth.
Okay,
That's what we just finished
I didn't
discussing.
put the wrong
We
one
just
up.
finished
That
that?
was
Yeah.
done. Now we're in 2B, which is
We're in
the
2B.
likely case model.
Okay.
And we can breathe. So 592 after-hours visits was what we actually saw The projected incremental loss there with mid-levels overnight is still $704,000. Now, just to put them in perspective,
Top one, we're now on 2C, I think. It says compare physician staffing versus mid-level staffing scenarios in likely scenario.
that's what's on top.
Okay, that's 2C. All right.
Okay. Essentially, what we're talking about again is the time frame of additional hours. If we staff the additional hours with physicians, you have $423,000 of net revenue in that scenario. The direct expense is almost $1.2 million. Okay. If you change from physicians to mid-levels, your expense drops by $248,000 in our model. And your net revenue decreases by $178,000. That means that the value of changing from physicians to mid-levels is $70,000 out of the $600,000 loss. You're not going to staff manage your way out of the magnitude of this problem that's caused by volume.
And the last one is the best case scenario, or which is?
If we look at the last one, is the best, same situation, best case scenario where we do have higher volume. In the additional hours using mid-levels, you have the same expense reduction. You have a slightly different impact on the net revenue. But the story again is you reduce your expenses 21%, causes your reimbursement to go down 38%. And again, you only save 10%. Now if, and it's the same in the other numbers, if money was our only object, we'd have already done this. But we've made a qualitative evaluation on what's the payoff, what's the value of the money spent. And that's where we go. You're not getting the bang for the buck by making that change because of consequences that flow through the reimbursement system.
Thank you. I think you go back to the table for a moment. Cross-examination.
So it looks like for the daytime hours that the urgent care is currently open, you're still content to staff it with ER doctors, is that right?
Yes, there's been
So
no,
You've not done the analysis to see what the savings would be if we had mid-level clinicians across the board?
we did that when we initially made the decision for the October 2013 opening. That was evaluated at that time, and the decision was made to go with the emergency room physicians.
Well, how much did you save over what you've shown us here for the 8-hour shift to mid-level? You must have saved more.
For the 8 hours? What,
The 12-hour.
which 12 hour?
You've got 12 hours you're having your ER docs, and you've got comparisons here with mid-levels after 8 p.m.
Mhm.
So what would be the actual cost if it was mid-level clinicians all day and all night?
We're not, we made that decision many months ago, and we were not reevaluating that
Well, I
decision.
assume when you made that decision, you had a number. I'm just asking you for that number.
We did then, but that's not in the scope of this discussion, so I do not have that number available now.
I feel like you're just giving us the numbers that you think are beneficial to your position and not allowing the community and the commissioner to see the whole picture.
Objection.
Sustained.
In the past, when you've made these analyses, you have estimated incorrectly, haven't you?
I have no idea what you're talking about.
Did you underestimate how much usage the urgent care operation was going to actually bring?
Well, when we made the move to urgent care on October 13th, the basis of our evaluation and setting a budget for that was, again, we've carried the consistency through, the number of emergency room visits that did not arrive by ambulance. And year-to-date through June, we had a slight variance in the revenue. We have achieved 11% more in revenue through July than we anticipated. In terms of the number of visits, we have received 36% more in visits, which was, as I said, and being consistent, the foundation for applying a best-case scenario.
Right.
That's
So-
what we are.
So you're testifying that it was actually used 36% more than you originally anticipated.
It was used 36% more than the number of people that actually came through. We had no basis to reach into the sky and grab a number. We used the statistics that were available, and yes, it has turned out different from that, and we have taken into account that difference in providing you with projections.
Well, not really. You've given us the benefit of what's actually materialized. What I'm offering to you is that since you estimated low the first time, maybe you're estimating low again. Maybe it'll be another 36%. You don't really know, do you?
All right, I'll let that question be answered, but not the first part.
Well, yes, to the extent that we were off, we did incorporate that. But in our background, we have from fiscal year '07, emergency utilization declining the following year 5.6%, declining the next year 2.9%, declining the next year 6.8%, declining the next year 6.4%, staying even the following year, and then in FY13 declining 5.1%. So we would not have been projecting by any rational method an increase. To the extent we did have an increase due to the change in nature, we've accommodated that.
It seems as though you're focusing on reimbursement when you're looking at the issue of staffing with ER doctors versus mid-level clinicians.
Jack,
That's
that's
the
not a
focus
question.
in the bottom line.
Well,
Is that fair to say?
let's say that's a question. Are you?
I'm going to say no to that because of the word focus.
Is that a major consideration in your decision to staff the urgent care with ER doctors, is that they are entitled to a higher level of reimbursement than mid-level clinicians?
That is not a deciding factor, because even though that's the case, it still costs somewhat less for mid-levels. So if money was our sole criteria, we would have gone with the mid-levels. But it's our doctors and our physicians and our clinical community that believes the slight marginal cost for physician care is providing better care.
But the costs are not totally told by reimbursement, are they? If we bring down the costs, aren't the patients paying less? Aren't the insurance premiums going to be less? Isn't there less cost with mid-level clinicians if you staffed the entire operation that way? Wouldn't that trickle down to the whole economy?
Urgent care billing consists of two components. There's the facility component, the hospital component, and the professional component. If we use the mid-levels, there might be some decrease in the professional component of those charges, yes. But at the expense then of jeopardizing the price decreases we've provided to all of the other patients throughout the entire county.
Isn't it true that when you look at who presents ambulatory to an emergency room and you're trying to speculate about who's going to actually show up for urgent care, there's not necessarily a clear correlation? You're not comparing apples to apples?
Yeah, that is true.
So wouldn't the best guess of what's going to actually happen be to try the urgent care and see if the numbers go up? Wouldn't that provide more relevant documentation than just speculation?
We did that. That's why we have the 36% increase in one of the scenarios.
We don't have the urgent care open 24 hours. I'm saying, wouldn't that give us the best numbers if we tried it?
It would give you real numbers. Yes, at what expense? How do you try something? You try it for 3 months, and then do you discharge the physicians and discharge the nurses? And how do you even hire them when you tell them this is going to be a 3-month trial so we can prove some numbers?
But that would be the best, the real number would be the best number, wouldn't it?
Theoretically.
Thank you.
Nothing further.
Thank you.
Our final witness from the rebuttal will be Frank McGinty.
If you'd raise your right hand. Do you swear or affirm the testimony you're about to give is the truth to the best of your ability and belief?
I do.
Thank you. Have a seat.
Thank you. Would you say your name again for the record, please, Mr. McGinty?
My name is Frank McGinty.
How are you currently employed?
I am employed by Maine Health. I serve as the system's executive vice president and treasurer.
And could you briefly synopsize your career as it relates to health policy matters?
There was a time when I referred to it as my short and checkered career. It's no longer short. I began my career at Blue Cross and Blue Shield of Maine, led its planning and research activities. In that capacity, was a major contributor to the drafting and passage of the Maine Certificate of Need Act. I moved from that position to Augusta, where I worked for the state of Maine for 13 years, including 6 as the state's deputy commissioner for health and medical services, where I presided over the implementation of the Certificate of Need Act, and then 5 years as the executive director of the Maine Healthcare Finance Commission. After leaving state service, I worked as a senior executive for Blue Cross and Blue Shield of Maine for 10 years. I've been in Maine Health's employ in my current capacity since January of 2001.
Thank you. Now, from a Lincoln County perspective, could you please speak to the question of the significance of the pricing of all medical services as it relates to the well-being of all the citizens in Lincoln County?
Yes, I'd be happy to do that. As other representatives of Lincoln County Healthcare have testified today, the prices that have been charged by St. Andrew's Hospital, Miles Memorial Hospital, and more recently Lincoln Health are either the highest prices charged by hospitals in Maine or very, very close to that. If they're very close to that, it's only because of the significant price reductions that have been implemented in the past year following the creation of Lincoln Health and its securing critical access hospital status. The prices charged for hospital services here in Lincoln County have created a significant hardship for the community. Certainly for any patient who is not covered by Medicare, Maine Care, or private health insurance, those prices are a significant burden. For businesses in Lincoln County that purchase insurance for their employees, those prices are a significant burden. Frankly, in addition to creating a significant burden for the community, those prices also create a significant problem for Lincoln County Healthcare. And it's the problem the Lincoln County Healthcare Board has wrestled with for the last 5 years, a problem that the boards of Miles and St. Andrews wrestled with before Lincoln County Healthcare was performed. The fact is that a hospital can charge what it wishes for a service. It then needs to negotiate an arrangement with Anthem or Aetna or Cigna to determine how much it will actually be paid. And here, the amounts paid, like the charges, are at the extreme upper end of the range. The highest in Maine are very close to it. And as I pointed out to these boards over the years, it's one thing to have a contract that entitles you to a certain level of payment. It's something else to expect members of the community to come to your institution for care and pay those prices. And in an era when increasing price transparency is the norm, where consumers are regularly encouraged to look for the best bargain for their healthcare dollar, either by state government or by their employer, and where consumers are being asked to pay a greater share of the cost of their health insurance coverage, either through deductibles or co-insurance amounts. The fact is that people have been leaving Booth Bay Harbor and this peninsula in great numbers to seek care elsewhere at a lower price. Whether they go to Brunswick, whether they go to Portland, whether they go to Rockland, whether they go to Augusta, they will regularly save significant sums by making that trip for their care. So, one of the challenges I said that the board of Lincoln County Healthcare faces is trying to find a way to reduce the amounts being charged to a more competitive level so that people will stay in this community and receive the care that Lincoln County Healthcare is capable of providing locally. And unless and until they do that, it creates a very significant financial problem for the organization. You've heard this morning testimony about critical access hospitals being entitled to cost reimbursement. Well, being paid roughly what it costs you to provide services by Medicare and Main Care is not sufficient. You have to attract a sufficient number of privately insured patients to not only pay for their care, but pay you for the care of those members of the community who don't have insurance coverage, don't have the means to pay for their care. So unless Lincoln County Healthcare can find a way to maintain a reasonable complement of high-quality services, services in which the community has confidence, and charge competitive prices for them, it faces an even more troubled future than Lincoln County Healthcare has had over the last several years, or Miles and St. Andrews had it before.
And how would compliance with condition number 3 adversely affect the system here?
So whether we're talking about a loss of $600,000 or $800,000 or somewhere between those poles, it would be necessary for Lincoln County Healthcare to do one of two things. One would be to raise the prices that it charges for services provided to privately insured patients. The other would be to curtail spending for other programs now in place. There's a serious problem in either case. Again, raising the prices doesn't guarantee additional revenue commensurate with the price increase. First, it's difficult to believe that the private payers like Anthem would readily accept such a price increase. But even if they did, the more important consideration, as I mentioned a moment ago, is that would simply perpetuate the movement of people from these communities to hospitals and other places for the care they need. In terms of reducing spending, there's also a problem there in that with a reduction in spending, Medicare and Main Care would both reduce their payments to the hospital. And so the hospital would essentially have to reduce spending by almost $4 for each $1 savings. So if you had to generate $600,000, for example, through reductions in spending, Lincoln County Healthcare's board and management team would have to find a way to reduce spending by approximately $2.4 million in order to achieve that impact on the revenue and expenses of the organization to try to keep them in balance. And that would have a fundamental adverse impact on the fabric of the services available in all of Lincoln County, including these communities on the peninsula.
Thank you, Mr. McGinty.
Isn't another area where you're losing a lot of money through electronic medical records?
No,
You're not losing any money through that?
no.
Haven't you had problems with the program?
We had problems implementing the system at Maine Medical Center.
And that didn't cost you anything as far as your overhead?
Hasn't cost Lincoln County Healthcare anything at all.
Isn't federal reimbursement for that program expiring in 2016?
No,
That's not?
no,
So you'll continue to have federal reimbursement costs for that?
we will.
Are there other areas of Lincoln Health that are losing money besides what we're talking about here today?
There are a number of areas of Lincoln Health that are losing money. As one of the foundation's witnesses has testified, it's highly unusual for not-for-profit hospitals not to operate services at a loss, that are paid for, if possible, by higher prices for other services. And Lincoln County Healthcare, Lincoln Health, like Miles and St. Andrews before it, are no different than other hospitals. What the board here has to do as Mr. Curtis testified earlier, is try to find a way to use the finite resources available to the institution to provide the best array of services that they can to the people of these communities. And they have made a judgment in a number of cases that there are services that should be subsidized. Most primary care physician practices, for example, require subsidies. But we all believe, I think, that having a strong primary care foundation is essential to maintaining a healthy community. It's not only important to the community, it's important to Lincoln County healthcare that we have a strong primary care foundation. It is important that we have within Lincoln County access to first-rate emergency services, and we still have that at Miles. And again, I suspect that the emergency department at Miles operates at a loss. That loss is within the overall picture considered to be a necessary, important part of maintaining a viable, high-quality local healthcare system here in Lincoln County.
So how far are we from that level of sustainable loss?
Well, you know, it's been very difficult in recent years for Lincoln County healthcare, and before it, either Miles or especially St. Andrews, to break even from operations, that generate enough revenue to cover the expenses. The board and management team of Lincoln County Healthcare, in my view, have done an exemplary job trying to find a way to reduce spending to maintain as many services of high quality as possible here in Lincoln County. And when they do that, they do have to make difficult decisions about what they have available to them and how those resources will be used to provide, as I said, the best array of services. No different in that respect than the gentleman who talked about the challenge he faced managing the delivery of services to members of our armed forces. He's got a budget, he has to make difficult decisions, and he makes them in good faith, trying to do the best he can in deploying those resources to meet the needs of the community served. That's exactly what the board and management team of Lincoln County Healthcare has been doing here. It's exactly why we place the confidence in them that we do.
We talked a lot about the skilled nursing beds being added. Wouldn't that eventually be a source of additional revenue?
Actually, it's not clear to me that those skilled nursing beds will generate sufficient revenue to support their operation.
In the past, when they were here, didn't we get outside sources filling those beds?
It's not a question of filling the beds. It's a question of whether the federal and state government, which will pay the lion's share of the care provided there, will provide payment rates that are commensurate with the cost of providing the service.
That's all I have. Thank you.
Thank you, Mr. McGinty. That's all we
Thank you.
have. Thank you. I don't know if we rest or anything in these proceedings, but
You can say that.
we have no further evidence to present, sir.
All right, thank you. Anything else?
No, sir.
Okay. Before I let the public start, I just wanted to give you a heads up. If you plan on giving me any written testimony, I have one here. You just know that it's going to be part of the public record, or this record, and then if you have any information in your submissions that are private, confidential, and you want them to stay that way, you might want to rethink submitting your written testimony and exhibits that might be attached. So I'm not going to prevent anyone from doing that if they want to. I just want them to know up front that other people will see this, and it might go beyond the commissioner, is what I'm trying to say. Okay? All right, we'll start with those in support. I think I've got this straight. In support of the exhibit or condition number 3, remaining. I guess if you want to make it simple, those in support of the foundation's position that want to testify, I'll be a little flexible with my 3-minute rule, but we'll see how it goes. Up at the top, I think I've got Captain Theodore Schmidt. Are you here?
Yes.
Yes.
I'll
Do you want me to keep
I'll speed
this?
things up and read it from right here.
Well, I'd like you up here if it's okay, because my mic won't catch you back there. Thank you. And if you could state your name and spell your name for the court reporter in the record, that would be helpful.
My name is Skip Humphrey, Humphrey. I am speaking for Captain Ted Schmidt, SCHMIDT. This is his experience as because of the closure at night. I am relating a personal experience. March 26, 2014, about 11:30 p.m., awoke with diarrhea and then vomiting. About 2 a.m., March 27th, it had subsided but left me totally dehydrated. Tried to call the PCP,
Primary care physician.
primary care physician at the hospital center to find the phones were out of order again. That's the third time in about a year and a half. I presented at the urgent care about 8:30, meaning that we got there and then had to go through the paperwork so that by the time we got into the emergency room, it was 8:30. Having had to wait over 6 hours to see anyone as to what to do about severe dehydration. Not a 911 need. Being the only patient there, I found an ER physician and 3 nurses, and in due course, 3 technicians, lab, x-ray, and EKG. The staff I encountered were excellent, and I was diagnosed with neurovirus and was sent to hospital because the violence of the reaction to the virus had caused greatly irregular AFib, now controlled. The ambulance ride cost $975. That 2 to 3 hour visit billed as St. Andrew's Hospital was $2,665.04. See CMS report excerpts. I do not consider this affordable care, which Maine Health and Lincoln County Health have touted for 2 years, but shows their entire program has been about the money. In addition, it is shameful business to threaten the public with a choice between 24/7 care for 18 months or skilled nursing beds because of the cost. The beds they removed from our peninsula, October 1st, 2013. Now their whole tune is about money, not patient health. And that's the end of his statement. And I would add that I've been hearing over and over again that there are towns in Maine with no ER and no primary care like we've got here now. That's not the point. You're missing the point. The point is we had a hospital, we had an emergency room, and Lincoln County Health and Maine Care took it away. Maine Health took it away.
Do you know if Captain Schmidt wants me to have that written testimony with the attachments? The written testimony I don't have a problem with, but
Yes.
he's attached diagnoses and...
Yes.
Take it, okay. I didn't think you wanted anyone else to have it. So I'll keep the testimony and give you that back gift of Captain Schmidt.
Thank you.
All right. Next person who wants to testify in support of keeping condition number 3. Yes.
Thank you for the opportunity to speak.
If you'd state your name and spell it for the...
My name is Edward Jaeger, Jager.
Thank you.
I have a year-round home in Southport since 1988. I consider myself a somewhat year-round resident of this town. I don't vote here because I have a place in Boston as well. In June of last year, a traumatic family event occurred, which I feel needs to be brought to the attention of this community. I think it's relevant to the issue of whether medical treatment will be available at the urgent care center on a 24/7 basis or just during the day and closed at night. I think my example also will clarify some real-life practical decisions and comments that were made today by the various people. On Saturday, June 8, 2013, my daughter Elizabeth, then 23 years old, was staying with friends in a sleepover that weekend. I was to go and visit her at 6 o'clock to 7 o'clock that night. Instead, I got a call around that time when an ambulance had arrived at Pine Cliff on Southport. Elizabeth was taken to the emergency room at the hospital. I arrived at the home she was staying at. EMT told me that her vital signs of blood, pressure, respiratory, pulse were extremely low. Didn't know what was wrong. Again, Elizabeth felt sleepy that day and went up taking a nap in the late afternoon. When I arrived at the emergency room, Dr. Tim Fox was there, and I'm glad he was. He tried to do what he could to stabilize her. Dr. Fox told me she must be airlifted out of this hospital to the trauma center at Maine Medical. He said, and I quote, "She will not make it to Portland by ambulance. It's too far away." So I've called in a medevac helicopter. When I arrived at the intensive care unit at Maine Medical, she was being kept alive on life support. About 6 to 8 hours later, because her situation didn't allow for surgery, she was sent down to the radiology department where they did interventional radiology and plugged the artery that runs from the spleen to the heart. Elizabeth spent 28 days at Maine Medical. She had 32 units of blood, equivalent to about 16 pints of blood during that period, the first 2 or 3 days. Now, one may ask, why is this experience relevant to the situation we face here today? And I'll tell you why I think it's relevant. In my daughter's case, the people she was staying with were intelligent enough and aware enough to know that her situation for a young girl, 23, who couldn't be woken up, was serious. In many situations, a person may not know themselves that their illness and their symptoms are severe and life-threatening. Their family may not know that. A good example of this would be someone having a heart attack, someone having a stroke. Happens all the time. People don't want to admit they're seriously ill. If Lincoln Health has its way, and the center is closed nights, other Booth Bay community members who feel ill, who may have a life-threatening condition, may not call an ambulance because they don't really understand what's going on. They don't know how ill they may be, how serious they are. Calling an ambulance in the middle of the night is a very, very stressful decision for the individual who feels ill, for the family member, and the community. So there's a tendency not to do that. They put it off. Now, in contrast, maybe, and I think it's human nature, that a more local resort to an urgent care facility at midnight or 3 a.m. in the morning would be something a patient, an individual would like to do. More reasonable to do that than to get into an ambulance and have a long ride to Miles, Brunswick, or even perhaps Portland. It's a well-known fact that the vast majority of people do not have the ability to ascertain the seriousness of an injury and have a natural tendency to not call an ambulance except in what is truly apparent to them and their family of an emergency medical situation. On the Lincoln Health's preferred operation of the clinic, oh, by the way, there was a number of people who mentioned this tonight about that possibility of people delaying seeking treatment because the alternative is expensive, the alternative is obviously somewhat, in my mind, very stressful. But Lincoln's Health Preferred Operation Clinic is the only alternative available after 8 p.m. for any medical diagnosis or evaluation. Or you just wait until 8 a.m. Or you take an ambulance ride. What it all comes down to is money and a trade-off between the health of the Booth Bay region community with possible deaths for saving dollars. This county and this hospital, this community has had a history, while I have been here recently, the last 25 to 30 years, of raising money for civic causes. The why? The hospital itself, which I understand was basically funded by the local community. There are a lot of people in this community who will help support a facility if it's needed. The commissioner, in her decision, said, and she recognized, by the way, to be de minimis losses possible, first 18 months to 3 years of operation. The commissioner said, and I think in her record, when she evaluated all this, it was in the best of the community's welfare and health. There may be alternatives to losing money, but it isn't all about money. This community could raise money if, in fact, it was needed to keep a facility open. I think the irreparable harm that's caused by shutting this down is that people will die. Irreparable harm is a legal determination that you can't correct by money alone or changing a condition. When people die, it's irreparable. When you lose money, you might be able to make it up somehow. And the problem we have with healthcare right now, it's all about the bucks. How about the people for change? And I recognize that money is a difficult thing to evaluate and spread around in healthcare. But I think this particular community has had a history of working out some of those problems. And I think it deserves a chance for 18 months, 3 years to figure it out. Thank you.
Could you leave that sign-in sheet up here? Could you leave that sign-in sheet up here?
I signed it earlier.
No, can you leave it here?
In the pen.
In the pin?
Oh, sorry.
I know you did.
I like the steel pens.
I know
Thank
you
you
did.
very much.
That's good. You can put, okay. Is that over there? Thank you.
Do you need to see it?
Yes. No, I-
Good afternoon.
Hi there.
My name is David Printy, Printy. I live at 8 Days Cove Lane, Damascotta, Maine, and I am a Medicare beneficiary. Today we have seen why Maine has a CON process up close and personal. I speak in support of the Commissioner's thoughtful decision to require a 24/7 urgent care center at the St. Andrews campus. Given the fact that LH and Maine Health did not file a CON application before the merger with Miles and the resulting closure of St. Andrews Hospital, I sit here today in amazement that they would challenge the Commissioner's decision, including the third condition. How many organizations would have the nerve to not follow the rules of Maine's CON process and then challenge an outcome that requires no significant penalty? It appears that Lincoln County Health did not want to be questioned regarding their decisions, even if they posed possible harm to the community. A recent comment by the LCH board chair in the Booth Bay Register has given some idea of the discussions in the executive suite of Lincoln County Health. I believe we are most fortunate to have such a talented DHH commissioner that rendered a rather compassionate decision given LHC's apparent disregard for the CON process. Healthcare facilities have a public purpose, no matter if they are for-profit or non-profit. That is why all must follow the CON statutes. We can only imagine how we find ourselves in this current situation. LCH was built and supported by community funds so that the residents and visitors of the Booth Bay region and the US Highway 1 corridor between Rockland and Brunswick had access in a timely manner to needed care. Over the years, different management, boards, economic conditions, and changing demographics produced fluctuating financial results. No matter the conditions, the community, including just vacationers, provided financial support to make sure they could go to sleep each night knowing that care was available if and when needed. What do we face as a community because LCH did not follow the rules? We now have no ER in Booth Bay. There's a agreed upon shortage of beds in the community. Financial losses in the current form, as stated by Mr. Donovan in the Booth Bay Register just last week. Physicians are leaving the community. We have now a less attractive healthcare organization for recruiting needed physicians. And residents and visitors need to travel outside our community for certain care needs. We have a loss of healthcare funds fueling our own local community. We have loss of good paying jobs, lack of confidence that any hospital or specialty service will be available in Lincoln County in the next few years. And quite frankly, the loss of respect for the people who supported and built both Miles and St. Andrews. In my opinion, following the required CON process from the beginning would have provided needed information and transparency, which would have caused the Board of Trustees and community leaders to challenge management's vision for LCH. Just listen to the thoughtful questions and comments made here today, and you will see what a mistake LCH made by not following the CON process that has resulted in a situation that our community does not have what it needs: timely, accessible care in their community. Yes, LCH has a mission, and some may say even a duty, but the lack of a clear vision is destroying what years of hard work and financial support have built, a legacy of trusted and nearby source of care. Thank you.
Thank you. You want to give that to me?
Yes.
For the commissioner?
Please.
All right, thank you.
In favor of keeping condition 3? Sure.
My name is Charles Asbury. I've lived here for 18 years.
How would you spell that last name?
Asbury, just like the park. One very minor thing in all of this, but when we talked about ambulance rides, you know, if you can go to St. Andrews, you may not need that ambulance ride, even one ambulance ride. You may find out there you don't, rather than having the ambulance take you all the way up to Damascotta and finding out it isn't that serious. That's just a minor point. I can't really add much to what was just said. I was going to say more about it. But, you know, we really shouldn't be here today. It goes back that if the board and all of these financial experts and if our representatives of Booth Bay, I'm not sure who they are, had filed that condition of need, they may have found that the community was very interested in what happens and could have put in some input that would not have put us in this situation. And as you know, we're here because the commissioner made a ruling. I was disappointed. I thought it should have been, we should have gotten more out of it. And so now we're here today to debate again how, whether or not they have to comply with these conditions of release. Of need. And it reminds me of my favorite movie, The Treasure of Sierra Madre. You know, with Humphrey Bogart, a lot of you have seen it. And they're standing there all up there in that place where they're mining, and the banditos come around them. And they say, "Give us your rifles. We're the federales." And one of the guys said, "If you're the federales, let's see your badges." "We don't need no stinking badges." And then they started shooting. And so it was sort of like that on this conditions of need. I don't know why they missed it, but I feel this attitude of we don't need no stinking badges. And I could say more, but I will go on. Thank you.
Thank you very much. In favor?
Hi, thank you for allowing us to speak. I'm Dr. Judy Stone, a practicing physician. I live at 117 Commercial Street over the hill and have been a homeowner here for the past 7 years and a summer resident for about 30 years. We never would have bought our home here had we known there would be no health care here readily available. I'm also a blogger for Scientific American and have written about my assessment of LCH's plans and betrayal of the peninsula there, and have submitted references to that effect.
Can you speak up?
Sorry. I thought it was at full volume. Here's a personal example of our need for 24-hour care. Last summer, my husband developed severe abdominal pain late in the evening, well after the urgent care center would have been closed. Although I limit my nighttime driving due to poor vision, I was able to drive him the few minutes to St. Andrew's ER, though it was dark and foggy. There's no way I could have safely driven him off the peninsula, especially given my level of stress at the time. With no urgent care, how many people will wreck because of the narrow, windy road being nearly impassable? All this driven only by LCH's profit motives. Having to be transferred over such a dangerous road, especially in bad weather, poses a needless hazard to the patients, EMT crews, and families who follow. And there's again good data about EMT mortality being higher than others. A 24-hour urgent care is the minimum necessary to meet the community's needs. A freestanding emergency room would be far better. It makes much more sense to have ambulances come to the urgent care, as it's so called now, which is misleadingly staffed as an ER with board-certified physicians, and have patients stabilized there. Although LCH refuses to provide accurate, transparent data to the community, it appears from the meager data they've provided that about 400 to 500 patients with emergencies were seen at St. Andrews at night, showing a true need for an ER. LCH cannot be trusted with numbers and planning. Their mismanagement is mind-boggling. Their poor decisions have left the community with the skeleton of the system that existed at the time of the merger just 7 years ago, and all done without the mandated Certificate of Need application. By transferring the critical access designation to Miles, it's reduced the number of beds in Lincoln County, which were already half of the 2.7 average per thousand average in Maine, to about 0.45 during the tourist season, comparable to levels of Pakistan and Afghanistan. LCH slashed the number of skilled beds and closed 25 beds here, yet now claim that reinstating 12 beds is a priority and that they don't have the $2.5 million to do this. So they're holding the application for skilled beds hostage to the decision on urgent care, despite data showing worse outcomes for recovery for elderly separated from family. What is needed here is an ER, not a Band-Aid from an urgent care, but even that is better. Even the limited urgent care that were 24 hours is far better than no services. Tell me again, Mr. Donovan, how is no care improving care for the peninsula? And how do you and Dr. Ferrari sleep at night? Thank you.
Thank you. The lady in the back,
Okay.
do you have written testimony you want to submit?
Yes, I do.
Thank you.
Yeah. I'm not going to clear those chairs down there.
Jeff?
Thank you. Whoever's behind me.
You've got something on the table here. Did you mean to leave it?
Sorry.
It's all right.
This is great. Is this okay right here?
Sure, wherever you feel comfortable.
Great. Thank you. Thank you. You're strong.
If you could state your name and spell your last name, please.
Greetings to the Department of Health and Human Services. My name is June Phillips, Junephill-Lips. I live at 1 Andrea Lane, Unit 19, Booth Bay Harbor. I didn't testify during the original hearing. Perhaps I was sick, as I quite often am. That's why I located very close to St. Andrew's Hospital. I have a condition, among other things, called AFib, which is apt to kick up at night, causing shortness of breath and low vital readings. When they go low enough, I need to be monitored and I need to have oxygen. An ambulance ride 2 miles, as nice as our EMTs are, is like a nightmare to me. Further pursued, why should precious time be wasted going 2 miles when I may need to go to Maine Med, as I did last December. As it turned out, my condition put me in mortal danger the whole time of the ride, as I had a spinal cord injury. Now, between December and April just passed, I was in Miles, Maine Med, Mid-Coast, New England Rehab, and a handful of small rehabilitation facilities. During each move, I had to wait days for a bed to become available. I was lucky to have gotten one on each case. It's very apparent to me there's a real shortage of skilled nursing beds, not only in our county, but at least as far as Portland. That's as far as it got. How could one even think of eliminating such a precious item, much less wipe out 25 beds, as when done when St. Andrews closed? This is not morally negotiable. This is life or death to us. If you have any questions of me, I stand ready to try to answer. Thank you for your kind attention.
Thank you. Do you want to leave that for the commissioner?
Sure. That's CAT approved, by the way.
I have a couple myself.
Okay. Thanks.
Next, in support of condition number 3 remaining. No, that's right. I missed his hand. You're next.
My name is Howard Wright, Senior, W-R-I-G-H-T. I have been a resident here or an owner since 1975, and proudly saying, I'll get myself in trouble, but since 1979, a Southporter. I'm 85 years old, young, whatever you want to call it. What I was going to say in a written testimony after sitting here, I have notes that just boggled my mind. I'm going to start off by saying for Maine Health and Lincoln County Health, this is a win-win situation. By that I mean even if the commissioner's decree is upheld, this organization of Lincoln County Health wins because it has put a stopgap to the 90 days of counting. Now, I can be way off the park or the ball game here, but we've heard about numbers, and I'm going to talk about numbers, first of all, not in dollars and cents, but in people. So, if Lincoln County Health can stall this degree long enough so the summer taxpayers, the summer people who come here visit, are not counted in, it's going to make their bottom line look so much nicer. Even if they do lose and they have to count in next year's summers, they don't have this year's summers to give a better baseline figure. I want to share something about a recent visit I had with urgent care. I ended up there with my wife a little after 6, a weekday. The place had been booked all day. All 10 beds or whatever it is was just full to capacity. I cannot say enough for the staff that was on that night. Even though they were running around, my entry sign-in was well done. I had to wait to see the doctor, but in that time, I was well taken care of. The doctor, and there were people there that were summer people that helped make the crowd. 2 ambulances showed up at different times to transport people. The doctor looked at my leg and was concerned about a blood clot. Said, okay, you're going to go to Miles. So my wife and I went to Miles. Fortunately, I didn't have to pay for an ambulance. The doctor here did an excellent job by calling ahead. I was there in about a half an hour. But Mark, I don't know whether it's your responsibility or who, but the entrance for a walk-in patient as compared to St. Andrews was as different as night and day. Now, I'm not talking about the doctors or the people, but whatever the organization, whatever the protocol is, I think it needs to be very, very improved. Anyway, I finally got in, put on a bed. A doctor came in and said, well, it'll be 2 hours. Now, this is after my doctor had called in, and they had a half an hour lead time to get the technician in. And I waited. And, you know, fortunately, there wasn't a clot. But a clot could have come, and we really would have been in, I would have been in serious trouble. So, what I wanted to then start to come back in, that I had been at urgent care a couple other times. And I know, Jeffrey, I think you said one time that whatever happens after 8 o'clock can wait until 8 in the morning. I believe I read that. Have you ever been to urgent care?
No.
No. So, these 2 things that happened to me were very correctly done at urgent care. But had they come at after 8 o'clock, I would have had to have an ambulance take me to Miles or Midcoast for no reason at all, except that the urgent care wasn't there. And these conditions were not conditions that could have waited that 8 hours until the urgent care opened at 8. There was a statement made earlier today about Miles and bringing in the technicians or whatever. My technician, who was great, could have been there well before I arrived, but didn't show up until after at least an hour. And when I did check in, I was told, oh, you've already checked in, after I had to re-check in after checking in at St. Andrews. I say this and ending up, I obviously am very biased. I'm an old-time board member of St. Andrews. When we were a board of community responsible people. We are not the 3-in-1 board that it is today. We did not have an abundance of paid physicians on our board. And lastly, I was the first mental health clinician on the staff of St. Andrews. My license had 6 zeros and a 47. I helped write the rules and regs to become a clinical counselor. It said that doctors need all this continuous work during the night in order to keep current. I can't do that. I can't address that medically, but I can sure address it mental health wise. I did not have to have a suicidal client come through my door every day to keep current. And believe you me, I had more than my share of suicidal clients. Most of my work was crisis work, and before cell phones, how many of you had phones in your bathroom? Well, all I can say is that there's a trust here that I feel Lincoln Health, Maine Health, needs to reestablish with this community. Thank you.
Thank you.
My name is Carol Burrell. I am a year-round resident of Booth Bay Harbor. In March, I was awakened after midnight with an ice pick headache and tingling and numbness on the right side of my head. It was unlike anything I had ever had before. Frightened, I carefully made my way to the medicine cabinet, looked in the mirror to see if my face were drooping, and I spoke to myself. I could speak, walk, and talk, which comforted me. I took Tylenol, the only painkiller I can take. I dressed and laid down on the bed, wondering if I would need to call 911 to be taken to Miles or Midcoast, and I have since learned about the stroke clinic at Maine Med. By 5 a.m., the pain had dissipated, and I thought of going to the urgent care center when it opened at 8 a.m. Instead, I had a neurological workup, including an MRI. What I remember most about this is the anxiety of knowing I live in a town where emergency services must be scrambled, and that does not comfort one at 2 a.m. or 3 a.m. or 4 a.m. when they're alone. The awesome weight of deciding if 730 people a year, which is the number bandied about as, quote, only 2 people a night might use the urgent care center, is on your consciences. Are only 730 people insignificant? I was and I am one of them. At 72, I do not feel insignificant. We need a 24-hour, 7-day-a-week urgent care center at minimum. The fact is, we were told when Lincoln County Healthcare decided that St. Andrews Hospital must close due to, quote, financial concerns, unquote, reminds me that we also were told that this was being done to keep Miles open a few more years longer than they projected before it too would need to be downsized or closed. Now to blame the urgent care center here as the reason Miles is seeing fewer people does not justify keeping the urgent care center a limited 12 hours a day. Thank you.
Could you spell your last name, please?
Burrill.
Thank you.
Does anyone want this?
If you want the commissioner to see it, I can take it.
I do indeed. Thank you.
Thank you.
Thank you.
My name is Ken McCormick, spelled M-A-C, capital C-O-R-M-A-C. I've had 2 bouts of cancer, one leading to a heart condition. I see the boomers are coming. I see more year-round people here than ever before, people building houses year-round, which is good for the community, which is good for the state. What I'm concerned about is the 8 to 8, because I really feel I need the 24-hour service because for a number of reasons. One in particular is I recently read where most heart attacks occur at night, around 4 or 5 a.m. So I'm taking my aspirin now before I go to bed. I used to take it in the morning. I need, and will need, or may need, more than urgent care here. I have an ICD that's monitored, which is an implantable cardioverter device. It's keeping me going, but it has to be evaluated, or would be evaluated, by someone here, particularly at night. So I'm asking that the 24-hour period be continued. It's needed in this community. We came here in 1968. We've been treated there, and I can tell you that people that are building houses here have money and are making a great contribution to the community and to the state. So I think you better plan on the future. I hope these numbers are audited by an outside reputable auditor. I've been in business for 52 years. I've run manufacturing companies. I've taken over companies that had 347 people. I reduced it in half, and we doubled our volume. Now I know that's not a medical facility, but I'll tell you, we have to find a way to reduce costs. And if there's an audit here, outside auditor, with comments about how the miles is run, or by Lincoln County Healthcare is run, I'd like to hear what they have to say about how those numbers are allocated. Thank you.
Thank you. Support of condition 3?
My name is Gary Arnold, A-R-N-O-L-D. I live in West Boothbay Harbor, about a half mile from the St. Andrews campus. Over the years, all members of my immediate family have required and used various medical services available at the time at St. Andrews, including emergency care for me, urgent care recently for my wife, extended wound care for a daughter, and residential care for my father at the old Gregory Wing. Our primary care physicians are affiliated with Lincoln Family Care. A few months ago, I was prescribed a series of physical therapy sessions for a bulky knee at St. Andrews. The services were offered in spaces once allocated to elder care in the old Gregory Wing, and in the middle of one session, an alarm went off for a routine fire drill. My therapist decided we should continue and ignore the drill, and I was at exercise beside a window overlooking the parking lot where the staff congregated after exiting the building. It was obvious to me only a few of them were wearing garb related to medical care providers, and I wondered aloud to my therapist how many of those folks were actually hands-on inpatient care or related testing folks. She looked over the group and after a moment said 3. There were 28 people in the parking lot. Now, we all know that these administrative support people serve all of the various main health locations, not just St. Andrews. They're there, based there because space is available. And my point here is not to necessarily pick directly at Lincoln Health on this, but to underscore the skewed nature of a national medical delivery system. Our situation here in Boothbay Harbor is a microcosm within this system, and I submit that your current deliberations on urgent care, and those before and yet to come, are taking place in this skewed context. Accounting ledgers, subject to manipulation and interpretation, determine the allocation of community medical services, and the patients considered essential are referred to as commercially insurable lives, quoting Mr. Donovan in the recent Boothbay Register article. I don't think that this structure can be maintained, so that major and permanent changes are being made in a 100-plus-year-old institution of history within a national system destined ultimately for significant fundamental change. Albeit hyperbole on my part, I compare the situation to the old storyline about the last soldier killed before armistice is declared. Round-the-clock availability of affordable, accessible, quality medical care should be viewed as one, if not the most important, overarching element for community development in both near and long term. It should not be viewed as passive service, but as a generator for economic development, population growth, tourism support, and, in our case, as a strategic location for marine and island needs. You'll generate a new base that will fill the void that fits into these charts that show we don't have sufficient numbers of people to support the services. For the last 2 years, I've participated in development of the revised comprehensive plan for Boothbay Harbor. In an otherwise fairly complete review, our deliberations on St. Andrews were pretty limited. There was no interaction with Lincoln Health, and no single administrator attended or participated at any time. I think here we've collectively caught up in a situation where through scrutiny of the wrong things, we've consolidated the delivery structure into a form so unwieldy that even the people operating it, that it does not focus on people, even so unwieldy even for the people operating it, that it does not focus on people, society, and the community, and it accounts those lives, again quoting, not commercially insurable, as a drag on the system. Something is fundamentally wrong with this perspective and the use of resulting calculations and projections as criteria for determining the importance of urgent care. Thank you.
Thank you. Have that. Thank you. In support of condition number 3.
My name is Patricia Seybold, S-E-Y-B-O-L-D. Like many of you in this room, I chose to live year-round in Boothbay after being a seasonal resident for 28 years. I'm 65 years old, my husband is 84, my mom will be 97 in 2 weeks. Like 60% of the residents on this peninsula, we're not young. There are about 7,000 of us who live here year-round, and about half of us are older folks who have chosen to live out the rest of our days here on limited fixed incomes. We did so in large part because of the welcoming people and the presence of a local community-supported hospital, St. Andrews. The other half of our year-round population are hard-working families and singles who struggle to make ends meet, especially in the winter months. Over 50% of their children qualify for federally subsidized school meals. So we are not a wealthy year-round population. For 5 months of the year, our population swells to the size of a small city, 24,000 people, as multi-generational families return each year to their summer homes. So averaged out, there are 14,000 people who need to be provided with local health services. At the current Maine average of $8,000 spent annually on health care for each person, this peninsula accounts for $116 million in health care spend. What we're here to talk about today is where and how should some of that money be spent? Shouldn't some of it be used to provide a 24-hour local safety net, keeping that money here on our peninsula? Should our healthcare dollars be spent close to home, providing an affordable, accessible, round-the-clock safety net for our aging families, for our aging population and our struggling families? Or should it be spent in Brunswick, Portland, and Boston, causing fear, anxiety, inconvenience, and needless expense? I know of over 10 families who have chosen not to return to Boothbay this summer because the oldest members of their families are too afraid to spend their summers here. I know of a dozen retirees who have chosen not to move here year-round, specifically because of lack of nighttime care options. When they don't come, their children don't come, and their children don't come. It's a death march for our community. We retirees, who are smart, committed, business executives from all over the world, are being told patronizingly that Maine Health can't afford to run a 24-hour ER or urgent care service at the toe of the Boothbay Peninsula if we also want access to local skilled nursing beds. That's not true. We had 25 beds that were used primarily for skilled nursing, rehab, and palliative care. Not only did Maine Health remove both the ER and those beds, they downsized the 38 beds at Miles Memorial to 25 in order to qualify for St. Andrews Critical Access Hospital Medicare reimbursement status. In short, after 3 illegal transactions, 1 hospital reorganization in 2007 without a certificate of need, 1 hospital merger in 2013 without a certificate need, and 1 bogus relocation of a hospital from Boothbay to Damariscotta, Maine Health has stripped this community of 24-hour emergency care and 25 skilled nursing beds, and stripped Lincoln County, the county with the oldest population in Maine, of 38 skilled nursing beds in order to gain a presumed $4.5 million in additional Medicare reimbursement. They spent $433,000 turning those skilled nursing rooms into a lovely physical therapy center. And now they're telling us that we need to come up with $2.5 million to build a new wing onto a retirement home to give us back 12 of the beds they stole from us. A retirement home, by the way, that they can then sell off to the highest bidder in the current investment bubble surrounding senior living communities. We're not that stupid. We are being harmed. We are extremely grateful to Commissioner Mary Mayhew for requiring that Maine Health provide our community with 24-hour urgent care service for 3 years so that we can all witness what its effect will be on our health, our peace of mind, and our local economy. Thank you.
Thank you.
I'm just gonna make one, please.
4, I think, right? Come on up. And you're next.
I'm Barbara Leonard of Booth Bay Harbor, and everybody else has said perhaps all the things that I want to say, but I do want to tell you how I feel and how I know many other people feel in this area. And I'm making this statement recognizing that the people of the Booth Bay region have probably lost their critical fight to the continued bombardment for the survival of basic health care on this peninsula due to the continued bombardment and attacks by LCH through press releases and manipulation. LCH should have honored the commitment documented in the definitive agreement that was agreed upon when St. Andrews joined Maine Health in 1997. We also acquired the designation of a critical access hospital, which required 24/7 emergency room care. At the time, this critical access hospital designation gave us 101% higher reimbursement percentage of allowable costs through Medicare and 109% of allowable costs through Maine Care. A loss of emergency room services resulted in the loss of this critical access care designation. I feel we've been set up to fail by both the subsequent departmental and board changes, construction, loss of beds, and new equipment, which was designated, used, and paid for as such, and moved to Miles Hospital. I feel what is happening is morally wrong, and the bottom line can be manipulated to reflect any outcome desired, and certainly I think it has been. Thank you. I appreciate it.
Do you want to put that in for the commissioner, or it's up to you?
Sure.
Thank you.
Another copy?
So this is my last one, but I've got loads.
Okay.
My name is Tom Hagan. That's spelled Hagan. And I live in Booth Bay. I'm in business. The interests of we who live in the Booth Bay region are being ignored by Lincoln County Healthcare. We need a medical facility open 24/7, even if it is just an urgent care center. 2 years ago, we learned, much to our surprise, that our hospital was to be closed. Many in the region were gobsmacked. Dr. Foray, known for his ability to sell ice to Eskimos, explained that it was not about saving money, it was for improving the quality of care. Today, Dr. Foray has a much tougher job. He must claim it is better to have no medical services available after 8 p.m. than to have urgent care services available through the night. He's trying to convince us Eskimos we're better off without igloos. We don't accept his claim. We want 24-hour urgent care on the peninsula. Jim Donovan says that if LCH keeps the emergency care facility open 24 hours a day, we may have to forego some of those price cuts totaling $7 million he talked about. Where did that $7 million come from? LCH announced the closure of St. Andrews 2 years ago, assuming that its critical access hospital status would be lost. That's why it was not about the money. The decision to close St. Andrews had been made even though closing it would cost more money. The task force set up in response to its closure by the 4 towns estimated a loss of $1.5 million in extra payments from the federal government due to the loss of St. Andrews CAH status. This notion prevailed for an extended period, almost a year. But then LCH came up with a different idea. St. Andrews CAH status could be saved by moving the CAH to Damariscotta. Furthermore, the move would not only save the $1.5 million otherwise lost, it was good for some $7 million, or thereabouts, of additional payments to the merged hospitals. That's where the $7 million comes from. Of course, the number of beds had to be substantially cut to the CAH limit of 25. Far too few for Lincoln County. Having eliminated all beds from St. Andrews and reduced the number at Miles, we must now add new beds to the Gregory Wing, which Mr. Donovan says we can't afford if we keep the urgent care center open at night. He would have us believe that the $7 million of annual windfall profits from moving the CAH to Damariscotta somehow won't cover the well under $1 million cost of providing additional round-the-clock urgent care. As for those price cuts, St. Andrews has always had CAH status, so why weren't its prices always lower? The Attorney General decided last year that it's legal for a nonprofit hospital chartered by the state to act in the interests of the corporation rather than the interest expressed by those served by the hospital. This was decided although its parent corporation had changed ownership of the hospital and then announced its closing, all without applying for the legally necessary certificates of need. And that parent had, by quoting 3 different lines from its audit reports at various times as its, quote, bottom line, deluded many into thinking the hospital was losing money. It has yet to be determined in a court of law that these acts were legal. But if they were legal, the law should be changed. Slavery was once legal in the state of Maine. It is no more. Thank you.
Thank you. Need one from Commissioner. Thank you. 4.
My name is Margaret Perritt, P-E-R-R-I-T-T, and I live at 58 Townsend Avenue in Booth Bay Harbor. I just want to make a short statement about the usage numbers that have been introduced into evidence by Lincoln Health. Since there is no history for an urgent care service on the Booth Bay Peninsula, it seems to me that to project future usage based upon past emergency department numbers is speculation at best. None of us in this room really knows what the numbers will be. We, the foundation, hear from community that they are happy to have urgent care, and especially if it is to be open 24/7. Lincoln Health, in fact, reports that visits to the 12-hour urgent care center since it opened on October 1st, 2013, have been far greater than they anticipated.
The fact remains that the history is being built as we speak. Commissioner Mayhew, in a bold and unorthodox move, required a 24/7 urgent care center to serve the needs of a community newly medically underserved, and she ordered it for 3 years. During those 3 years, a history will be built and a set of usage numbers based not upon speculation but upon fact will be developed. I encourage the commissioner to hold fast. Her idea is a good one, and at the end of 3 years, we will know if it is a proper fit for the Boothbay Peninsula. Thank you.
Thank you. Four.
Good afternoon. My name is Connie Machon, M-A-C-H-O-N. Let me tell you the story of my mother-in-law, who is 97 years old. She was born in Boothbay Harbor, as was her son and grandchildren, all at St. Andrew's Hospital. My husband, who is her son, and I help her out around the house and with getting her out for coffee and errands. Last winter, she had to make the dreaded trip to Miles ER in the middle of the night 3 times. 2 of the 3 trips were during snowstorms with slippery roads and crazy drivers passing on curves. 2 of those 3 trips or cases could have been treated at urgent care 5 minutes from her home if it had been open 24/7. So you can see how we need urgent care around the clock in Boothbay Harbor. Thank you for coming and listening to our pleas.
Thank you. Thank you. 4.
Good afternoon.
Hello.
Angela Imhoff, I-M-H-O-F. Been coming to the Boothbay Peninsula for 44 years, since before my last son was born. I own a property here, as do 2 of my daughters. My sons and my granddaughters come and visit regularly from New Jersey. My concern is, as I age, do I want to stay here in the summertime, or do I want my families to come with children that can require more than a 12-hour urgent care? But what I have here is a statement from my son-in-law, Stephen Davis, at 14 Lincoln Street in East Boothbay. Dear sir, madam, I understand that you are collecting comments from people, etc. I've been a summer resident for the last 12 years. I've been fortunate enough to not have needed the urgent care. My brother and his family came out the week of July 28th for a week-long stay at a rental cottage on Southport. They were all the way down to Neweghan, which those of you who are familiar with the peninsula know that that's quite a distance from Miles. They brought my mother from Michigan. She's 80 years old. She had lost her husband recently. It was her first trip. Unfortunately, at 8:30 on July 30th, she stumbled and fell on a deck, and the urgent care was closed, so she needed x-rays. We drove the distance to Miles. She was in a great deal of pain whenever she had to move. The irony was not lost on me that I had to drive her right past St. Andrew's Hospital to go up to Demerskata. They determined that an x-ray and a CAT scan, she had a fractured pelvis. At 2 o'clock in the morning, we were informed that they had no beds, and she would be taken by ambulance to either Lewiston or to Portland, because there were no beds in Midcoast as well. After much discussion, they elected to keep her overnight in the emergency ward, as either Portland or Lewiston would have been a hardship for my family to get to her. As it was, Demerskata was hardly convenient coming from Southport. I can only imagine what it would have been like in the winter months. She ultimately was released on Sunday to fly back to Michigan. We were tremendously fortunate that her injury was not any worse. The fact that there is no 24-hour urgent care in the region seriously will impact my decision to ultimately retire here. Both my daughter and son-in-law are educators in New York City, so they would certainly be valuable contributors to this community, as is my other daughter, who is an attorney and also teaches law enforcement and criminal justice in New Jersey, and she has her home up at Wall Point. So that would also be, she decided not to retire here, that would certainly be, would be a loss to the community as far as I'm concerned. It seems completely ridiculous that a region like ours, with an elderly summer population, with many people who are working or having fun during potentially dangerous activities, that they do not have sufficient urgent care. I truly hope this can be rectified. Thank you.
Thank you.
Thank you.
4. Don't be shy.
About the ones that haven't been read in yet.
I have several.
So we have quite a few from people who are no longer here.
How many is quite a few?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So we could read them into the record, or we can hand them to you.
How about handing them to me?
I'm sure
And
that's
the
what
commissioner
it
will
is.
have them as part of her record to read.
Okay.
Thank you. Anyone left to speak for condition 3 remaining? Last call? Okay, yes?
My name is George Doran, D-O-R-A-N. I live at 39 Union Street, Unit 3. I didn't intend to say a word today. I guess I'm what you call a newbie. I've been a resident here for 4 years. I've spent an enormous amount of time in hospitals. I'm a 3-time cancer survivor, twice melanoma, once lymphoma. And so when we purchased our cottage here, we give consideration primarily to 3 things. Right at the top of the list is hospitalization, followed by church, followed by library. Everything else falls into line. Boothbay Harbor, 4 years ago, 3 years ago, 2 years ago, even today, exemplifies for us supreme happiness, well-run village, town, county, what have you. I'm dismayed and encouraged by this today. I'm encouraged, I'll say first, by the attorney for, and I'm not dismayed at all by the opposition, except to say that listening here to these hours, it's apparent to me that whether you're talking about morally or financially or what have you, that there certainly has been enough evidence for this situation to one more time to be revisited, to give consideration to the pro. I'm a little bit confused at the fact that this hearing was scheduled on a Monday morning at this particular hour, because as I look around, I'm sure I'm the only one that has his true color hair, but I look at blue and blonde and yellow and gray and none, and I'm a little bit saddened by the fact there probably isn't anybody in here in the vicinity of 20, 30, or 40 years old. Those who are will hit me over the head when I get to the parking lot. But I think, I don't know most of you. I do know some of the speakers today. I think people, at least pro, have spoken for the most part, certainly eloquently. They've spoken from the heart. They've spoken from true experience. And there's nothing like experience to reveal one's true feelings. The facts are clearly although they're on the table and an enormous amount of research has been done, it's terribly obvious from the pro attorney that there are many figures, numbers, what have you, whether they be just numbers or dollars, are in dispute. So in closing, I want to thank you, sir, for conducting a very respectable hearing. It's been fun coming to it, and I really look forward to the results. I have to go home and feed a dog and do that, so I'm not here. I won't be here to hear all the con, but you can bet your life I'm going to read each and every article on the con side for the balance of the afternoon. Thank you.
Thank you. Last call for 4, condition 3 to remain. Going once, twice, done. Those in support of Lincoln County's proposal that condition 3 be done away with? No one? Those that are neither for nor against that want to speak? Yes.
My name is Andrew Twaddle. I'm a professor emeritus of family medicine and sociology at the University of Missouri.
She'll definitely want the spelling of your last name.
Twaddle.
Thank you.
And I didn't come here intending to speak, so I have no prepared statement. But I have served as I'm a social scientist by training. I have served as on the faculty of the Harvard Medical School and been a research fellow in medicine at the Massachusetts General Hospital. I've served at the University of Pennsylvania, and for the past 40-some years I've been at the University of Missouri, where I've been professor of family and community medicine, professor of sociology, director of the medical sociology program, and chair of the Department of Sociology at various times. I'm really here just to let you know that there is, on several points that have been discussed here, a research literature, which this is being my summer residence, I don't have all this at my fingertips, but I can provide you with references if you so desire on any of these points. One is that health is multidimensional, that we have talked here in terms of disease and death as 2 indicators of health. That have been seen to be a primary concern. I've heard no discussion of illness or sickness, which are the major motivators for people to come and to seek medical care. And this is an area with we're the oldest county with the oldest state of the union, and the aging in this peninsula has been very, very rapid over the past 20 years. And so we're seeing as a situation where healthcare needs are quite a bit greater than are evident right now in the system, but which are likely to grow substantially. Secondly, there is a difference in the research literature between technical quality and quality of care. And technical quality refers to the things that you've heard about preventing death, preventing morbidity, and quality of care issues really have to do with support of people who are suffering. And so medicine pays very little attention to quality of care issues. Nursing is much better at it than medicine. And it's an issue I think needs to be taken into account, because a local community hospital provides quite a bit of support for people who can be cared for close to home and have the support of their relatives and friends, which is much more difficult at a greater distance. Third, let me read my writing here. I can't. There's a international comparative literature on healthcare reform, which indicates that there are at least 3 models that are in the literature. One is a professional model in which the professions basically organize and run the healthcare system. It's the model we had prior to the failure of the Clinton Health Plan in the 1980s, at which point the health insurance companies came in and took over the system. That is a corporate business model, which is what we're seeing displayed today in the decisions of Lincoln County Health. The third model is a democratic one, which we've never really had much of in the United States. It's much more common in the European sphere. And we know through all these models that the market model is the least cost-effective of all three. That both the democratic model and the professional model were able to operate the system much more effectively, both in terms of cost and in terms of outcomes, than is true of the corporate model. And the third thing is that one of the things we see internationally going on now is a process where the medical care system, however it's organized, is trying to minimize its costs by externalizing them, getting it passed off to the community. And clearly one of the things that's happening here is that the cost to the Boothbay Peninsula communities is going to be manifest in higher taxes, in higher transportation costs and the like. And that's an externalization coming from the healthcare sector. So I just wanted to let you know that there is a literature on all of these, that there's a substantial amount of research. I'd be glad to pull it together and get you references if you so desire. And thank you.
Thank you. Any either for nor against that want to speak? Okay. That will conclude the public speaking session. I indicated that I would give the attorneys a chance to do a brief closing argument. They will have an opportunity to do more thorough written closing arguments that will be submitted by the close of business this week, Friday. I had earlier also mentioned to the attorneys, and I can't remember if I said it to anyone else out here, that I was going to allow same period of time for any members of the public that weren't here to submit their written statements. I've changed my mind because I think it's only fair that the attorneys who are going to do their written closing arguments have, number one, access to all the evidence to do those, which they wouldn't do if I left the record open for additional written statements until the same day their arguments are due. So as soon as I get back to my office, I'll be copying all of these and scanning them to the attorneys, so that's the fastest way to get them to you. So in any event, the record's closed now with regards to further public comment in written form or orally for that matter. So how much time do you think you want for the oral?
Very short.
Short?
Very short.
Okay, then I can wait. What I'll do is, since the applicant has the tougher road, I guess if you will, I'm going to let you do a closing. I'll let you do your closing, and then if you have any rebuttal closing, I'll let you do that.
Thank you. For a number of reasons, I want this to be very brief. Obviously, this is addressed to the commissioner, and the commissioner is not here, and there's not much point in my making a speech at her. We'll file a written paper, and I'm sure she will read it. It is certainly disappointing to hear so much disappointment about the efforts that are being made by Lincoln County Health to try to juggle a lot of issues for a lot of people in a very senior county. And the focal point here, and I particularly appreciate the professor's broad perspective, but all we were allowed to talk about here today is Condition 3 on a certificate of need issued a while ago with respect to applications filed a long time ago, and rebuilding the American healthcare system is something I'd love to talk with you about sometime, but we really can't get into that here. And we have felt constrained, and I think the community needs to know, we have been limited by the scope of the reconsideration that was allowed, and to the extent that you're disappointed that there's too much focus on the dollars and cents, that was the issue the commissioner invited us to submit our evidence on, and because that was the question that was left open by her addition of this condition after all the previous submissions had been made. And I don't want to get out front of my authority here. I'm just the lawyer. But I happen to have a turn to talk and everybody else doesn't, and I think I'm able to say for all the very talented, hardworking people at Lincoln Health and Maine Health, they are working a very hard problem, and they're working at it very hard. And it's disappointing that choices that get made are disappointing to people who are important to them, and I can only hope that these things will get resolved. On the merits of this proposition, we think the key point has been determined by the scope of the reconsideration. We think that the financial evidence that's been provided shows a cost that cannot properly be justified given the kinds of impacts those costs will have. And we will elaborate on all of that in our written submission, and I thank you very much.
Thank you.
We don't actually have very much evidence at all of what an urgent care facility that's open 24 hours a day is going to generate in business, because we don't have one. We're making all of these decisions based on speculation that's provided by Lincoln County Healthcare. Why should we rely on that on such a life or death decision? They've been wrong before. They can very well be wrong again. They just recently underestimated the current usage of the 12 hours that the urgent care facility is open. Who's to say they wouldn't drastically underestimate the 12 hours that it were open at night? We deserve a chance to see how this plays out. The commissioner made a very thoughtful condition based on her hearing from this community. And if this community hasn't been heard from today, then I don't know what else would happen, because this is something that's very important to everyone that lives here. It's not just lives that are going to be lost, it's the very fabric of the community that will change. And it'll change forever. It'll never be brought back. And this is just the one more service in a long line that we've lost. What will come next? The next step will obviously be that we can't have the 12-hour urgent care open. And then what comes after that? It's just a very slippery slope, and if we don't hold on tight to what we have, we're not going to have anything.
Thank you.
I think we're done. Thank you very much.
Thank you all. I will close the hearing. As I indicated before, the record, what I packaged together and sent to the commissioner, will stay open just for the written closing arguments from the attorneys, and then all of that goes to the commissioner. And the attorneys, of course, will get copies of everything I send. Thank you all. Have a good day.